Thank you for joining the Nonstick Nuisance Medical Monitoring for PFAS webinar today. My name is Andrea Amico. I'm a PFAS community leader from Portsmouth, New Hampshire, and founder of the advocacy group Testing for Ps. I'm honored to introduce today's session. We have a few logistics to go over before we start. Here is our amazing lineup of presenters today for our hour-long presentation. And here is information regarding the funding for the Mid-America Pediatric Environmental Health Specialty Unit program and the disclosure. It is our goal that by the end of this webinar, you will have knowledge on what PFAS are, where PFAS are found, why we are concerned, potential health effects associated with PFAS, and how you can monitor your patient's health. Now we will hear from Dr. Linda Birnbaum, who will provide an overview on PFAS. Thank you.
Hi, it's really my pleasure to be here today and to be able to introduce all of you to the topics of per and polyfluoroalkyl substances, or PFAS. I'm Linda Birnbaum, and I'm the former director and currently a scientist emeritus at the National Institutes of Environmental Health Sciences, part of NIH, and the National Toxicology Program. I'm also a scholar in residence at Duke University. I served for 40 years in the federal government, and it was wonderful to be in a situation where I was responsible for no one but the American people. So what are these per and polyfluoroalkyl substances? And I apologize for the horrible name, but it encompasses a huge number of substances. EPA now has on their website over 12,000 of these chemicals have been reported, either intentionally made or unintentionally the products of environmental degradation, for example. So again, there are the products, there are impurities in the products, and there are the degradants. If any of you have had Teflon pans or Scotch guarded, say, your carpets or some of your clothing or your tablecloths, that all contain PFAS. The film-forming foams that are used to fight fires, the AFFFs, there are many formulations we have no idea what they are. Many of these compounds, such as the ones that you can see on the right of your screen, the PFOS and the PFOA. The PFOS, by the way, was used in Scotchgard, and the PFOA in Teflon. What you can see if you look at these, all those little lines are representing carbon-fluorine bonds. This bond barely occurs in nature, and it is extremely hard to break. So why do we use these? Well, they're very useful chemicals in industry and in our homes. They provide resistance to grease and water and oil. They function as surfactants and stain repellents. These chemicals, as I said, partly or in large part because of that strength of that carbon-fluorine bond, are persistent in the environment. They also are very mobile in the environment, so they're not just where they're produced or where they're used. I can tell you that some of the indigenous peoples of the far north are heavily contaminated by these compounds, and many of them, specifically things like the PFOS and the PFOA, accumulate in our own bodies. Now, the short chain alternatives, those are the two at the bottom, the PFMOA and the Gen X, have fewer carbons, but they've got lots of fluorines. Of the short chain alternatives, very few have a lot of data on them, only a couple, but the little data that they have suggests that they do very similar things to the long chain ones as well. So I think the question is, how are we all exposed? We find them in drinking water, either because they're near a place where they were used or they're getting there from our sewage treatment plants. We find them in carpets and fabrics. We find them in food packaging and food and pots and pans. Many of them are present on our clothing. Some of them are in cardboard packaging. I've mentioned several times the AFFF, and they can be present to pretty high amounts in different kinds of cosmetics. So we're exposed to them if they get into our food. We're exposed to them from by ingestion. If they're in our drinking water, we also ingest them. And you may not like the idea of this, but we're all eating dust all the time, especially our little ones who are closer to the floor and put everything in their mouth. But some of these compounds, when they're released or when they're heated, can also go into the air, either as vapors or as bind to particulates in the air, and we can inhale them. And some of them can even get to us by getting on our skin. So there is a really wide range of health effects that we've seen from PFOS and or PFOA. Now, not every study finds the same things, but there are enough studies to believe that we're beginning to see the effects I'm going to mention. And I should mention that essentially all these effects that I'm telling you have been seen with PFOS and PFOA. We have also seen in our experimental animal models. So I'm not talking just rats and mice. I'm also talking monkeys. I'm talking birds. I'm talking fish. So some of the things we have seen that are associated with these compounds are testicular cancer and kidney cancer. We also see things like ulcerative colitis, which is an effect, an autoimmune effect, impacting the immune system. I'll come back to immunotoxicity later. We're seeing some pregnancy-induced hypertension, including some evidence for preeclampsia. We're seeing, in many cases, disruption of our thyroid system. We're seeing effects on our hormones in addition to thyroid. So we have seen effects on our estrogens and on our androgens and testosterone, as well as some of our other hormone systems. There is growing data about impacts on the liver. I can tell you that in our animal models, the liver is always an impacted organ. And there was a systematic review and a meta-analysis published really confirming the impacts on liver function in people. We're also some data showing impacts on increased risk of obesity, and some data showing that type 2 diabetes may be increased. I mentioned the immunotoxicity before, and in fact, what has been seen in a multitude of studies in different populations and with different vaccines is an inhibition of the vaccine response. There's some evidence for lower birth weight and size for babies. There's evidence for delays in puberty, decreases in fertility, and even early menopause in women. And then there is some evidence really not only for prostate cancer, especially if there's a family with an elevated risk of prostate cancer, but also ovarian and bladder cancer as well. So what I'd kind of like to leave you with is that these PFAS are multi-system, and I should say multi-species toxicants. As I said before, it's not just rats and mice. It's animals, many, many animals throughout the animal kingdom, as well as people. And we're not talking about something that only affects men or women or only affects us during early life stages in utero or young children, but all stages can have effects. And essentially, every organ system, at least in some models, has been shown to have an effect. So with that, thank you for listening. And I hope that this gives you a good introduction to the potential problems that we may all be facing with PFAS. Thank you.
Hi, I'm Phil Brown, University Distinguished Professor of Sociology and Health Sciences at Northeastern University and co-director of our PFAS Project Lab. You've been hearing a lot about PFAS. I want to let you know that this is a class of over 14,000 human-made compounds with a very long history starting in 1938. DuPont began to produce them as early as 1951. The problem with this is that during all the time, there was a lot of industry secrecy and deception. As early as 1961, DuPont found liver toxicity in animals. The next year, they found toxicity in humans. Women on the production line were having birth defects, and instead of cleaning up the process, DuPont simply moved them off the production line. When 3M tried to find workers and people elsewhere in the world as a comparison group, they couldn't find anybody uncontaminated. At first, we thought PFAS were mainly coming from the production facilities of the big companies and from companies that use those chemicals to make other things like waterproof fabrics. Then we started to see a lot of problems with AFFF firefighting foam. Then we saw landfills and wastewater treatment plants, the sludge that came out of them, and the fertilizer that came out of those wastewater treatment plants, sludge, and the food that was grown on farms where that was applied. We have continual expansion all the time. Metal plating shops, oil refineries and rigs, artificial turf, pesticides, dry cleaners, and all sorts of plastics. Now, how do we learn all this? Very much of it is from affected families and people who are in proximity to production sites. The DuPont site in West Virginia bought land from the tenant farm family and dumped over 7,000 tons of PFOA there. Every cow on that farm died. Now, this resulted not just in a big fine from EPA, but a major lawsuit and a very important health study that you're going to hear more about today. Community groups have always been central to toxics issues, and these groups that you see here that we work with have raised public awareness, have helped get regulation, have helped make publicity through journalists. They've gotten medical education and medical monitoring on the agenda, and they have helped to create new research along with scientists. What are the things that these folks are concerned about? They want to know, what are the health effects? Who can tell us about this? Are these exposures the cause of my illness and my family's illness? And how can we get monitoring to check our health over the years? We want to know where we can get blood and water tests and who's going to pay for them. How can we avoid exposure? And how can we make sure that medical professionals are very widely aware of this and able to help us? Next, you're going to hear from a woman whose medical monitoring and treatment saved her life.
In 2017, I learned that the drinking water my husband and I used for 25 years had been contaminated by PFAS. My home was across the street from a Christmas tree farm, but that had been a dump site for tannery waste from Wolverine Worldwide, and my husband and I had no idea of that. I actually learned about this a year after my husband died quite suddenly from liver cancer. I was told by our Department of Environmental Quality that I needed to test my water for PFAS. My water came back initially at 38,000 parts per trillion, which is much higher than the EPA health advisory of 70 parts per trillion. We drank that water for 25 years. I had asked to have my blood tested, but I was told by the health department and just various state agencies that there was no need for that. Luckily, my lawyer helped me find a place that would do testing. And while it was quite cumbersome, eventually I learned that I had PFAS levels in my blood that were over 5,000 parts per billion. As a layperson, these numbers mean nothing, and I had no way to put this into perspective. So I made an appointment with my primary physician, and frankly, he looked as puzzled by this as I did. But the steps he took next really made all the difference. I remember the appointment because he politely excused himself and then returned with the information on PFAS from the ATSDR. I had already found that information and was pulling it out of a folder at the same time, but I felt that he at least had heard me. He had recognized the importance of what I was saying, and he was taking steps to find out information. And that was really key for me as a patient. We agreed that the information from ATSDR wasn't terribly helpful, but we reviewed it together and we agreed that the next steps would be, one, not to panic. 2, I would do whatever I could to reduce further contamination. And 3, we would do some monitoring of those issues that were identified in research already. This meant maybe some extra labs at my annual physical, monitoring kidney function, thyroid function, etc. He also added an exposure to environmental toxins as a diagnosis in my chart so that other health providers would take this seriously as well. Then we fast forward to 2020. I began having some just benign symptoms that we talked about at my physical, just some shortness of breath that would come and go, clearing my throat, weird sensations in my throat and neck. And we first ruled out just the easy things, allergies, GERD. But the next appointment, my physician said, typically this would be about 20th on the list, but given your high PFAS levels, the prudent thing to do would be to rule out any problems with your thyroid. I had an ultrasound and it was found then that I had thyroid cancer, which had actually spread to some lymph nodes. And as a result, I had a total thyroidectomy and 23 lymph nodes removed. And I also had radioactive iodine treatment, and now I'm continuing to be monitored. I was very fortunate to have incredible attentive doctors and medical staff here working with me. I had a medical team that included me, the patient, as really part of the team. They provided me with information that was really clinical and relevant. They found a really good balance between reassurance, reminding me that this doesn't predict anything technically in the future, but also realism that it was something that we had to be aware of. And we talked about the research to date, and we continue to talk about that every time I have an appointment. They used my levels as part of any medical history, just like you would any smoking, any history of diabetes, any other environmental exposure. And they validated the concerns I had. They didn't discount my worries or minimize them, but they explained them in good clinical terms. I'm very excited that we're doing these trainings, and I hope this information helps doctors moving forward when they have patients like me. So thank you for taking the time to watch this.
Sandy's story illustrates some of the PFAS concerns we hear expressed in a clinical encounter. I'm Alan Ducketman. Today, I want to talk about health outcomes and medical monitoring linked to PFAS exposure. A quick word about my background. I'm an internist, an occupational physician, and a frequent contributor to the PFAS peer review literature. My disclosure is that I've developed medical monitoring for PFAS-impacted communities, including in legal disputes. What is medical monitoring, and when should we do it? In 1995, the Federal Agency for Toxic Substances and Disease Registry, the ATSDR, provided general guidance for determining whether or when medical monitoring is appropriate after an adverse exposure event. This guidance was published in the Federal Register. Medical monitoring for health outcomes linked to toxic exposures can be considered when routine tests can detect problems early, and one can provide a useful intervention to prevent or mitigate an adverse health effect. For PFAS, medical monitoring can look like taking an exposure history, ordering a blood test, counseling on exposure reduction, counseling on health behaviors that reduce the odds of disease, or monitoring and diagnostic testing for specific health outcomes linked to the exposure, in this case, PFAS. Several groups have published PFAS medical monitoring guidelines and recommendations. This slide lists some of the main ones that we will cover in this lecture. The first arose from the C8 Health Project. This enrolled 69,000 people from six contaminated water districts in Ohio and West Virginia, beginning in 2005 to 6, with some substantial re-enrollments for longitudinal follow-ups. The results were interpreted by an independent panel of 3 epidemiologists known as the Science Panel. Their conclusions about health outcomes associated with PFOA exposure led to the creation of the first PFAS-centered medical monitoring in the US around 2014. Later, ATSDR asked the National Academies of Sciences, Engineering, and Medicine to convene an expert interdisciplinary committee to advise federal agencies on PFAS medical monitoring. We'll cover what the National Academies Committee concluded and how ATSDR responded. Finally, we'll look at PFAS REACH recommendations for medical screenings. REACH is a collaboration between researchers and clinicians, including me, to provide resources for clinicians and impacted communities. The science panel identified several health outcomes linked to high PFOA exposure, leading to medical monitoring program for affected residents. I want to focus on the lipid, kidney, and thyroid outcomes for a moment. Footnote 1 is my view that we have increased evidence of harm for lipid and kidney cancer outcomes in the year since the panel made their determinations. And footnote 2 is my view that today the thyroid story is more complicated, but could be of concern for subpopulations, notably pregnant women or those with pre-existing circulated antithyroid antibodies. This PowerPoint lists the outcomes considered for medical screening of that exposure population. The outcomes were stratified by age, including adverse effects on lipids, thyroid, ulcerative colitis, kidney cancer, and testicular cancer. Years later, the National Academies made similar determinations as the science panel. The 2022 National Academies report naturally considered more studies that had been published since the time of the CA Health study, and note that outcomes were added in the 8-year interval, such as liver enzyme elevations. This PowerPoint represents my personal view about outcome evidence based upon primarily human and also animal studies. The listed outcomes are more likely than not causal. The columns from left to right are in order of certainty using language intended to assist patient understanding. Strong evidence means we can be certain or near certain. Substantial evidence means substantially more likely than not. Simply, more likely than not means just that. We think there is causation, but the evidence could evolve. You should know that the outcome list continues to grow, not shrink, as more research is done and more evidence is provided. There are thousands of studies about PFAS and health outcomes, a topic deserving at least its own hour lecture. And I can't cover everything, but we can at least consider an outcome about which we can be certain or near certain to illustrate the evidence: lipid metabolism. There are more than 50 studies in over 30 populations with different kinds and levels of evidence and study designs, including longitudinal studies, clinical trials, cross-sectional studies, and of course, these then have meta-analyses. There's increasingly strong physiological explanations in humans for the outcomes and across laboratory and wild species to explain the findings. In addition, the human population studies indicate that PFAS exposures lead to increased numbers of people with lipid levels higher than recommended thresholds for pharmacological treatments, for example, for total and LDL cholesterol. Another outcome with strong evidence is PFAS had impacts on the liver. A meta-analysis in 2022 showed higher PFAS exposures were linked with higher ALT. That's the most specific biomarker of liver disease. Other enzymes such as AST and GGT are also affected by PFAS. Studies also reported that PFAS exposures are associated with metabolic dysfunction-associated steatotic liver disease, or MASLD. For example, a cohort study published in 2026 found that a doubling of PFOA or PFHPA in the blood of adolescents is associated with increased odds of MASLD as defined by hepatic fat fractions on imaging. Clinicians are accustomed to pattern recognition. The PFAS profile of worse lipid, liver enzyme, and uric acid profiles are also the biomarkers elevated in the well-known metabolic syndrome. So you will not be surprised to learn that I'm concerned that studies show that PFAS exposure exacerbates insulin resistance. including meta-analyses of studies done in human populations, and even in a clinical study after childhood bariatric surgery. And these studies show how PFAS may be related to diabetes, an evolving topic. The National Academy's report provided expert recommendations for medical screening and guidance. Their advice was to start with exposure assessment. Ask questions about drinking water in your patient's community or about occupational exposures. For deeper questions, one could ask about diet and fish consumption, especially local fish in contaminated areas, or older carpets or upholstery in the home, or use of takeout food containers, especially if takeout containers are frequently microwaved or heated. The National Academies also provided benchmarks for the additive sum of 7 common PFAS that can be measured in human serum. This sum of 7 is a measure of internal exposure that is repeatable and can be used to inform medical monitoring. When the sum is above 2 nanograms per mil in serum at the time of blood draw, consider whether medical monitoring is appropriate. Note that blood levels of the best studied compounds such as PFOA and PFOS have declined in the past 2 decades and continue to decline. This is primarily due to the phase out of PFOS and PFOA in the US manufacturing market. What this means for interpreting the sum of 7 is that one should consider past as well as current exposures and the half-lives, information which could be obtained during an exposure history. And the half-lives of PFOA and PFOS are on the order of 2.5 to 3 years. For those who are or may have been above 20 nanograms per mil, the recommendation for medical monitoring becomes more general. The 20 nanograms per mil level is routinely exceeded in communities with contaminated water or in specific occupations. The group with some serum levels higher than 20 nanograms per mil is also the group I'm most concerned about. A word of warning: testing costs. PFAS blood tests are generally send-outs. They can be expensive. Depending on the practice location, they may or may not be covered by insurance. Later in this lecture, Dr. Laurel Shader will provide more information about blood testing. There are many pathways to PFAS exposures, and clinicians can help to identify, manage, and reduce these exposures. Clinicians can advise on exposure reduction at the individual and community level. For example, it can be effective to advise individuals or communities about water filters or other ways to reduce exposure to PFAS in homes with a contaminated water source. Home water filtration works provided the right filter is used and properly maintained. Specifically rated carbon filters should adequately remove older legacy PFAS, such as PFOA and PFOS, if properly maintained. Newer, more expensive filters will be needed, however, for some of the replacement compounds. Individual home filtration of PFAS is also burdensome, not a cheap nor easy thing to do. Ultimately, finding clean water sources or instituting water district level filtration is more effective and less expensive compared to multiple points of filtration at the individual home level. What advice do we give about breastfeeding and pregnancy? Unfortunately, PFAS readily pass transplacentally and also transfer to infants in breast milk. These unfortunate characteristics are a source of parental stress. Currently, we do not generally recommend delaying pregnancies despite the transplacental transfer. In addition, the National Academies recommend breastfeeding when possible, even in the context of a PFAS-contaminated mother. The rationale is simple. Clinicians are generally reluctant to lose the known benefits of breastfeeding newborns if breastfeeding is possible. This reasonable advice is made complicated by the fact that studies indicate that PFAS contamination decreases the likelihood and duration of successful breastfeeding, including in studies in mothers who at the time the studies were done had no way to know that they were PFAS contaminated. It can be helpful to honestly explain that recommendations are based upon our best sense of competing risks and benefits. So long as we've discussed our recommendations and their honest limitations, we can be supportive of patient decisions about breastfeeding and timing of pregnancy, either way. The report from National Academies made recommendations for federal agencies, including ATSDR, the federal agency tasked with overseeing the medical and public health of exposed populations in the United States. In response to the report, ATSDR has not revised its medical monitoring recommendations. Instead, ATSDR published a web page of resources for clinicians in 2024, but it does not include medical monitoring. The 10 regional and federally funded pediatric environmental health specialty units are also listed here as a source of information, including a fact sheet from the Mid-Atlantic unit. PFAS REACH also provided up-to-date medical screening guidance comments. These are easy to access, free of time-consuming prologue for the busy clinician, and they list familiar and relevant lab tests for adult and pediatric patients. The tests cover lipid, liver functions, uric acid, serum creatinine and thyroid screening, and urinalysis, based on health outcome evidence that we covered in this lecture. In addition to the tests listed, my personal view is that evidence supports an estimated glomerular filtration rate, which is achievable from the recommended tests, as well as consideration of non-invasive assessment of stages of liver steatosis and fibrosis using the FIB4 or other similar algorithms, or even liver elastography if indicated for the sensitive patient with risk factors. As clinicians, professional societies advise us to be more consistent in addressing the emerging epidemic of MASLD in any case, and we could certainly be more proactive in populations with risk factors ranging from obesity to PFAS exposure. Sometimes doctors hear questions from a patient about enhanced PFAS excretion. This has been a common question for family planning, for example, but I've heard it across the age spectrum. There are no FDA-approved treatments for decreasing PFAS, but we know a few things that do hasten excretion. High-fiber diets help a little. In addition, bile acid sequestrant medications, serial phlebotomy, and apheresis with a properly selected membrane could be effective. Of these, bile acid sequestrants are probably the most practical. The data on the slide comes from an analysis of the C8 Health study. The highly significant difference between those taking and not taking cholestyramine is visible, especially for PFOS. Clinical trials have also measured decreases in PFAS levels from cholestyramine or similar bile acid sequestrants, and some come in easier to use pill form. Okay, a lot of ground covered in a short time. One does not have to be a PFAS expert to consider familiar topics such as liver, lipid, and kidney outcomes. If you have follow-up questions, my contact is on the PowerPoint. Thank you.
My name is Nate Barber, and I have been a firefighter for the last 15 years. Over those years, I had multiple exposures to PFAS and AFFF and firefighter turnout gear. We regularly trained and used foam during fire suppression and drills as a municipal firefighter. We also trained with airport firefighters with AFFF. Every day I worked at the firehouse, I was also exposed to the protective gear that I wore. The gear had multiple layers that contained PFAS in all of them. 2 years ago, I found a lump on my testicle that turned out to be cancer. I was diagnosed with seminoma that had spread to the lymph nodes of my abdomen. I received an orchiectomy and radiation to treat the spread at Mass General Hospital. Shortly afterwards, I researched causes for testicular cancer and came up with a link to PFAS. Testicular cancer is common in the fire service and common with PFAS exposure. The fire service also has higher rates for prostate, kidney, and liver cancers than other occupations. The use of PFAS chemicals in the fire service was not only heavy, but also consistent. Every day we wore our gear, we exposed ourselves a little bit. Every time we used and handled the foam, we exposed ourselves in high doses. Imagine taking buckets of PFAS and dumping it into trucks and then spraying it all over an area you are working in. These exposures to the fire service are still ongoing and have been accepted tactics by the fire service for years. We were even told in the early training days of our career that AFFF is just like Dawn dish soap. At no point were firefighters given any guidance on managing, handling, replacing, or the health issues connected to AFFF or their gear. There were no warning labels or safe handling protocols followed. Firefighters eat, sleep, work, and exercise in a firehouse that is suffused with PFAS dust. Forever chemicals are on every surface they touch. We need to look at where we can avoid any unnecessary exposures to PFAS to protect our 1.2 million firefighters that protect us. So keep this in mind when you see a young, healthy firefighter in your office. They may think they are invincible, but in reality, their health has been compromised due to exposures at their workplace. Thank you.
My name is Elizabeth Friedman, and I'm a primary care physician at Children's Mercy in Kansas City. I work as the medical director of the Environmental Health Program and also as the director of the Mid-America Pediatric Environmental Health Specialty Unit, or PACEU for short. The PACEUs are a national network of experts in the prevention, diagnosis, management, and treatment of health issues that arise from environmental exposures from the time of preconception through adolescence, and we're dedicated to providing consultation and training for health professionals and the public on environmentally related health effects in children. As such, I will highlight some of the practical things clinicians can do to address patient concerns about PFAS exposure, and I'll share some perspectives on how clinicians can think about PFAS chemicals as a class of chemicals, as well as some relevant questions we can ask ourselves when thinking about PFAS exposures. As mentioned previously, while we have learned a lot about this group and potential health effects of exposures, there's still a lot we don't know about PFAS. Currently, researchers are exploring questions like how much is needed to see changes at the cellular or physiologic levels and over what period of time? How do we metabolize them, if at all? Do we eliminate them, and if so, how? And do different types have an additive effect or different effects altogether? And then there's this question, should we wait until we have proof of harm and measurable harmful dosage before taking action? Many environmental health experts would say no, that we have enough information to make informed decisions about how much PFAS we should allow in our environment. And this brings me to the precautionary principle. This statement implies that there is a social responsibility to protect the public from exposure to harm when scientific investigation has found a plausible risk, that the burden of proof should not rest with the public as it does now, which ultimately shows adverse outcomes once the chemical is in the environment when it's too late to prevent exposure. For many PFAS, for the ubiquitous, more historic ones, some would say we are well past the precautionary principle, that we know more than enough about the harmful effects to remove them from industry. But then, what about the other thousands that may differ by only a few molecules? Should we still allow those? Short chain and ultra short chain PFAS are emerging types of PFAS chemicals. Some are breakdown products, others were introduced to replace the ones we've learned are harmful. And it's important to note here that they don't have to be proven safe before they're used in an industrial setting. These newer PFAS have fewer carbons, tend to have shorter half-lives, are more mobile, and can pass through standard carbon-based water filters. Researchers are still studying and learning about the health effects for most of these PFAS. Gen X is one of those short-chain PFAS, and we've learned that Gen X exposure can result in similar health effects to long-chain PFAS. So the effects of PFAS exposure are still being discovered, mostly based on these ongoing toxicologic and epidemiologic studies. Unfortunately, many of the epidemiologic findings are based on studies from communities that have been highly contaminated due to lack of regulation or sometimes even illegal disposal practices. Consider what happens when there's a chemical we know is harmful to health, but we continue to use it widely throughout society, like lead, which is a well-known environmental hazard. We have known lead was harmful to some degree for millennia, and today we're still trying to remove it from our infrastructure. And while we do this, we monitor the blood lead levels in children and in adults who may have been exposed at the workplace. And then after we find someone who's been exposed, then we intervene. Another interesting point that might add some perspective is the difference in how we approach pharmaceuticals and chemicals. Right now, pharmaceuticals are considered unsafe until they're proven safe. But we don't apply this process to chemicals we use and encounter in everyday life. So what's our role in the clinic? Clinicians need to have sufficient knowledge and resources to respond to their patients' concerns. In my practice regarding PFAS, I have seen three main types of patients. There are those who have developed a horrible disease or have loved ones with a horrible disease, and they wonder if PFAS exposure was the cause and what to do about it. There are those who've been exposed to high levels of PFAS or have presumably been exposed to high levels of PFAS, and they worry if disease is inevitable, and if possible, how to reduce their risks moving forward. And this may include how to potentially remove PFAS from their bodies. And then there's that larger group of people who are concerned about having been exposed to PFAS because they know these chemicals are ubiquitous and they want to know how to reduce their risks moving forward. To answer some of these questions, environmental physicians may be most suited. However, given the widespread concern and ubiquity of these chemicals, it makes sense for all of us clinicians to have a basic understanding of the content we are discussing in this presentation. And for all of us to be able to provide scientifically sound answers, we need to continue to support and participate in medical surveillance. And we need up-to-date resources to provide effective and timely risk communication, as well as intervention for individuals with prospective and known exposures. Here's another case example to reflect some of these ideas.
Hi, I'm Jamie Hunkawa, the co-founder of the PFAS Action Group. After learning about PFAS through my community work and reading countless articles and studies, I decided to see just how much PFAS I had in my blood. After consulting with my primary care physician and providing them with the clinician guidance documents from PFAS Reach, I was able to discuss the importance of the test and ultimately convince them to authorize the lab order through Quest Diagnostics. I want to make a note that it did take some discussion and a lot of research on my end to provide my doctor with the information they needed to feel more comfortable about approving the blood work. And I appreciate their willingness and respect for my desire to better understand my personal exposure to these chemicals, which resulted in them ordering the test. A few weeks later, I received my results, and my physician was honest and open about not knowing how to interpret them or what they meant. But we discussed published studies on health outcomes and were able to develop a plan for future monitoring, as well as discuss exposure reductions. Additionally, having my results gave me a baseline to work off of and illustrated how my levels compared to the national average provided by the National Health and Nutrition Examination Survey, or NHANES data. Since learning of my levels, I've made changes in the products I purchase, have installed water filtration in my home, and will continue to monitor health conditions associated with PFAS contamination with my physician. At the end of the day, having clinicians such as yourselves understand the implications of PFAS contamination and be willing to learn and advocate for your patients about PFAS will be instrumental in empowering patients like myself with information on our exposure levels. Thank you so much.
Hi, my name is Laurel Shader. I'm a senior scientist at Silent Spring Institute. We're an independent nonprofit research organization focused on understanding links between everyday chemical exposures and women's health, with a focus on breast cancer prevention. My own research focuses on exposures to PFAS and other toxic chemicals through water, food, and consumer products, and how our health may be affected by these exposures. Today, I'll be talking with you about PFAS blood testing, when PFAS blood tests are appropriate, what we can and can't learn from a PFAS blood test, how to interpret the results of these tests, and some information that may be helpful for you if you're looking into ordering PFAS blood tests for your patients. Public health agencies such as the CDC and the Agency for Toxic Substances and Disease Registry have typically thought of PFAS blood testing as most helpful as part of scientific investigations or health studies. However, attitudes towards PFAS blood testing are evolving. A 2022 report by the National Academies of Sciences, Engineering, and Medicine recommended that clinicians should offer PFAS blood testing to patients who are likely to have a history of elevated exposures. There are a variety of reasons why individuals may seek out PFAS blood testing. These tests are helpful for providing an indication of each individual's personal level of exposure to PFAS. This information can inform medical care. For instance, for people with elevated exposures to PFAS, it may be appropriate to follow up with certain types of medical screening for health effects linked to PFAS exposure. Results of PFAS blood tests are also a useful baseline for future comparisons. For instance, if a source of contamination in a community is remediated, or if an individual takes steps to reduce their own exposures, it's helpful to see if their PFAS blood levels go down over time. Finally, having the results of PFAS blood testing is useful for potential future research studies because this would provide an indication of exposures closest in time to when contamination is discovered. As a healthcare provider, you may feel reluctant to order a PFAS blood test for your patients. You may be concerned that your patients will feel overly worried to learn that they have elevated levels of these toxic chemicals in their bodies. From what I've learned, talking to residents in many PFAS-impacted areas, I've heard over and over again people say that having this information is important and empowering. As one advocate said, ignorance is not bliss. A PFAS blood test provides an indication of the levels of certain PFAS chemicals in a person's blood at the time of the test. For some PFAS, like PFOS and PFOA, these chemicals can stay in our blood for years. So the result of a PFAS blood test for these chemicals provides an indication of exposures over an extended period of time. Newer PFAS chemicals stay in our blood for shorter amounts of time, like weeks to months. So for these types of PFAS, blood tests provide an indication of exposures to these chemicals over a shorter period of time. Note that for newer PFAS, these are less likely to be included in commercially available blood tests and less likely to be detected with available lab techniques. The results of PFAS blood tests can answer questions like, are my levels of exposure higher than the general population? And are levels in my blood higher than other people in my community? It's important to keep in mind limitations of PFAS blood testing. From a PFAS blood test, we can't know for sure where the PFAS in a patient's body came from and how they were exposed, although looking at the relative amounts of various PFAS chemicals can provide some clues about sources. We also don't know how long the PFAS have been in a patient's body. Current tests don't capture all the different types of PFAS that people are exposed to. As you've heard, there are thousands of different PFAS chemicals, but currently available tests only capture 7 or maybe up to 40 or 50 PFAS chemicals. So we're not getting a complete picture of exposure. Patients may wonder whether a health condition they're experiencing is related to their PFAS exposure. While public health research has provided links between exposures to PFAS chemicals and increased risk at a population level, it's not usually possible at an individual level to link a chemical exposure with an individual's health condition. And finally, we can't know for sure whether a patient will develop specific health conditions in the future related to their PFAS exposure. As a clinician, you may wonder how you would interpret the results of a PFAS blood test with your patient. As a starting point, it's helpful to know if a patient's levels are elevated compared to the general population. To make these comparisons, a helpful reference point is the CDC's NHANES study. NHANES stands for National Health and Nutrition Examination Survey. This includes PFAS blood testing in a representative sampling of people in the US. We know that PFAS blood tests can be difficult to interpret. To support people in understanding results of these tests, our PFAS Reach team developed a free online tool called What's My Exposure? This tool is based on Silent Spring Institute's extensive research into effective methods for chemical report back. The tool allows users to enter the results of PFAS blood tests, and the tool in real time provides graphs and text to put these results into context, as you can see on the screen. The tool also provides exposure reduction tips and other information to help people feel empowered to use their results to protect their health. You can also use the tool to interpret the results of water testing as well. In addition to making a strong recommendation about offering PFAS blood tests to patients, the 2022 National Academies report also developed clinical screening guidance based on a thorough review of published scientific studies. The guidance is based on the total amount of 7 common PFAS found in people's blood. On the right, you'll see a table from the NASEM report. This table shows suggested screenings in 3 categories based on the results of PFAS blood tests. Many of these screenings are within the normal standard of care. On the bottom, you can see a graph created by our What's My Exposure tool. Once you enter a patient's blood test results into the tool will automatically help you interpret the results within this NASEM framework. If you're looking into PFAS blood tests for your patients, here's some information you may find helpful. On the screen, we've compiled ICD-10 codes, CPT codes, and test codes related to ordering PFAS blood tests. Please note that these codes may change over time, and they may vary by state and billing method. For updated information, you can visit this tool on our PFAS exchange at bit.ly/PFAS blood test. There are a handful of options currently available in North America for PFAS blood testing, and there's some differences among these options. Some of these tests include a wider range of different PFAS chemicals, and some include a narrower range. Tests that have more target analytes provide a better sense of a person's overall PFAS exposure. Labs also differ in their detection or reporting limits, a measure of the sensitivity of the test. Tests that have a lower detection or reporting limit are more sensitive and will provide more information about lower levels of PFAS in a patient's blood sample. Finally, a quick word about chemistry. Some PFAS, like PFOS and PFOA, are present in the environment and in our bodies as a mixture of similar chemical structures called isomers. Some tests look for both linear and branched isomers, and that provides a more complete assessment of the level of that specific chemical in a person's blood. Other tests only look for linear isomers. And so with these tests, we're only seeing a portion of the level of that chemical in a person's blood. It's important to keep these differences in mind when you're making comparisons to NHANES or other benchmarks. Your patient will likely also have questions about insurance. Currently, New Hampshire is the only state that requires insurance providers to cover the cost of PFAS blood tests broadly. Other states are considering similar legislation. You may want to have your patient check with their insurance to confirm coverage. You may also want to keep in mind that patients may opt to search for PFAS blood testing on their own. One available option is an at-home finger prick test offered by EmpowerDX. Dr. Courtney Kerrigan, who you will hear from shortly, led a study to validate the accuracy of this test compared to conventional phlebotomy-based methods. Quest Health also offers PFAS blood testing directly to patients in some areas. For more information, please visit our PFAS Exchange website. On the left, you'll see a link to our online resource with information about specific PFAS blood testing options. And on the right is a general guidance fact sheet with information that you and your patients may find helpful. Thank you for learning about PFAS blood testing.
My name is Courtney Kerrigan. I'm a professor at Michigan State University and a co-lead of PFAS Reach. And I'm going to show you how to navigate the PFAS Exchange for information on blood testing using our exposure tool and medical screening companion guidance, joining our clinician listserv, and finding this recording and attached list of additional resources for future reference. You've heard about the PFAS Exchange from other members of our team of PFAS researchers, doctors, and community partners. It was developed as a resource hub as part of our NIH-funded PFAS Reach project and has been cited by the New York Times and by the National Academies. If you navigate to the PFAS Exchange on the browser of your computer or phone and click the clinicians link, you will have a menu of options. There are 2 links that have information on blood testing. One is a document that has information about blood testing, including ICD, test, and CPT codes for ordering a PFAS blood test. Health insurance may cover the cost, which is a few $100s, but people often have to self-pay. We've compiled more information about different testing options, which you can access via this link, and navigating the tabs at the bottom for detail about tests from each lab, as well as information on codes. This was initially developed for people to access testing on their own. Now that it's available, many providers use Quest and their panel of 9 PFAS works well for exposure to legacy PFAS most likely to be reported in drinking water, as well as past occupational exposures. Once you have results, our exposure tool can help interpret results. Click Get Started and enter results to get a graphical depiction of where they fall relative to the general US population median and 95th percentile. There's an option to download and print the report in the bottom left. The report also shows where results fall relative to the National Academy's medical monitoring guidance. Currently, most people fall in the moderate range of exposure, for which medical screening guidance reflect routine preventative care. You can find more details about these guidance in the National Academy's report or in our companion medical screening guidance. Our guidance for clinicians provides specific guidance on additional testing to consider for adults and children with elevated PFAS exposures. Our companion guidance for people in PFAS-impacted communities provides background on PFAS exposure, health effects, and medical screening. You can find a link to our drinking water fact sheet to learn more about where to find a lab to test your water for PFAS and resources to find filters for removing PFOA and PFOS in drinking water. One of the more accessible options for water testing is through a company called Cyclopure. Dr. Ducketman mentioned that cholestyramine is a medication that's effective at removing PFOS from the body more quickly. You can get more information about that and other options by joining our listserv for medical and public health professionals to share information on PFAS. You can join by sending an email with the subject line subscribe to PFAS and patient care at msu.edu. In the email, please note your name, any credentials, and why you're interested in PFAS. You can also email me directly and we can add you manually. You can find these instructions on the Nonstick Nuisance page of the PFAS Exchange, along with a video of this training, and link for a document with a curated list of additional resources, which should also be available to download at the end of this presentation. Thank you for helping protect our communities from PFAS.
This concludes our Nonstick Nuisance Medical Monitoring for PFAS webinar. We hope you have found this information helpful. Thank you.